we're just going to focus today primarily on the scoring systems of pneumonia. I'm going to give you a little bit of just basic epidemiology. Eighth leading cause of death among Canadian adults. The overall mortality rate is about 10 per 100,000. Again, this does vary depending on where you are in Canada, as you can see. And more specifically, when you actually break it down into age groups, as expected, very low mortality among young adults, and as you get to be, increasing in age, your mortality increases substantially. So what we wanted to see was why do young people get pneumonia in the first place? A study that was done in 2010 wanted to look at what the determinants were of community-acquired pneumonia in previously healthy young adults and children. I won't go into the details of the study, but they did identify independent risk factors for community-acquired pneumonia, and these were asthma, increasing of age, 3 or more recurrent upper respiratory tract infections, smoking, and interestingly, having 3 or more children at home. So these are why patients get pneumonia. That's not necessarily pertinent from an emergency room perspective. We're not really concerned as to why they got their pneumonia. We're concerned as to what's going to happen to this patient. So another study done in Alberta wanted to look at the factors that are associated with mortality from pneumonia in young adults. The overall death rate in this population tended to be a little bit higher than we would expect to see, but they did identify independent predictors of mortality, and these were age being greater than 40, being sick, female was actually a protective factor, admission to a hospital, and that's just basically because bigger hospitals tend to get the sicker cases from out in the periphery, and aspiration. And they also did notice that there was a significant portion of patients that had a mortality relatively quickly to their diagnosis within the first 10 days. They looked at those patients and they found that they were all aspiration pneumonias. So pneumonia scoring systems, let's use them for risk stratification. We want to be able to identify patients that are at risk for severe pneumonia, as well as patients that are low enough risk that we can confidently treat them as an outpatient. Most of the scoring systems so far that we use on a daily basis are 30-day mortality. There are a few scoring systems that are being developed or that have recently come into play that do try to predict the need for ICU admission. They've been derived primarily from studies in inpatients, and we wanted to see how well are these scoring systems when applied to young adult populations. So the big one that we know of is the Pneumonia Severity Index. These are the variables that are used to calculate the scores. Basically, you're risk stratified depending on what your score is into classes 1 through 5. And depending on which class you fall into, that can help guide you as to whether or not you're going to send this patient home as an outpatient or have them admitted into hospital. So the initial study was done in 1997. The authors of this study at that time saw a great variability in hospital admission rates for community-acquired pneumonia. They thought that it might be secondary to physician uncertainty as to who should be admitted into hospital. So they wanted to derive a prediction rule that would accurately identify patients that were at low enough risk that they could be sent home, as well as they wanted to also make an attempt at looking at secondary outcomes in this population. So this was sort of a 2-part study. First, they needed to derive their rule. They used a very large database to identify independent predictors of mortality in patients with community-acquired pneumonia. They then took those independent predictors and, based on a previously validated index for community-acquired pneumonia, they then derived their prediction rule. And they wanted to derive a rule that was actually a 2-step process that would mirror the thinking of a physician at the bedside. Step 1 is patient sick or not sick. Step 2 being, if the patient's sick, how sick are they? They then took this rule and they further validated it again, this time being in 2 different cohorts, retrospectively in the same database that they used for the derivation of the rule. And then they also followed it prospectively in the port cohort. They followed these patients for 30 days after their diagnosis to see what their outcomes were. And this was the population that they also were able to measure the secondary outcomes, such as ICU admission. So these are your 2 steps. Step 1, there's 11 factors that you can determine based off history and physical exam. If a patient meets none of these factors, then they can be assigned to class 1. If they have any of the 11 factors, then you have to go on to step 2. You add on another 9 factors, you calculate the score, and then you risk stratify them based on their score. So it's pretty easy. Now there's problems with when you're comparing for young adults in this population, how well the PSI will predict their outcome of interest. So for us, class 1, they have to be less than 50. So for the purpose of our presentation today, class 1 is going to be the most relevant to the young adult population. Mean age that they said was about 35 to 37, and as you can see, fairly low mortality. However, mortality is not the outcome of interest that we want to identify in young adults. As we all know, the mortality is low. We're more interested in ICU admission, failure to be treated as an outpatient. So further looking at this class specifically, we can see that in total, for patients that would be classified as low risk by the PSI, and that's classes 1 to 3, there were 7 deaths overall. Only one of those deaths was in class 1. But also within class 1 specifically, 5.1% of outpatients required further hospitalization, one of them being into the ICU. And over 75% of class 1 patients that were admitted initially had length of stays longer than 4 days. So in conclusion, we want to say that the PSI is good at predicting 30-day mortality in those under 50 years, but it's not as good at predicting our outcome of interest, which is the need for inpatient treatment, ICU admission. So use caution when using it in young adults. So the next study done, or that we looked at, was the CURB-65 study. Again, this was a study there they wanted to derive a prediction rule that would accurately identify patients that were lower risk for mortality from community-acquired pneumonia. They, again, derived the rule in an inpatient population. They initially applied the modified British Thoracic Society assessment tool at that time, which was the CURB score. At that time, there was only 2 results. You were either severe or non-severe. So they wanted to examine the association of that score, as well as other clinical variables, and derive a prediction rule that would better stratify based on their risk of mortality. So once they identified the independent predictors, they created their rule, which we know as the CURB-65. Groups 1 had relatively low mortality. Those are scores 0 and 1. People in group 2 were intermediate. They could be treated with either a very brief inpatient stay or outpatient with home care. And people with a score of 3 or more were recommended for inpatient treatment. They also wanted to take a look at how well the CRB-35 could perform. This was for primary care physicians who did not have a urea level, and they found similar mortality and risks as compared to the CURB-65. So when you're actually looking at how well it's performing, it's not too bad as we would expect in predicting mortality. Particularly groups 0 and 1 would be our groups of interest. However, again, it's measuring 30-day mortality, which is not very useful for a young population. They didn't actually provide as many details as to what happened to their patients. So we know that about 5% were admitted to the ICU. I don't know the breakdown. So the take-home message from this is that this rule was derived in an inpatient population. It measures 30-day mortality, which is not our outcome of interest, and so you need to be cautious when using it in young adults. So problems with the PSI and the CURB-65. They measure mortality, as we've already sort of discussed. The main rationale with using these scores is the risk of death. For young adults, the outcome of interest is not mortality, so they're often underclassified. These scores are also not able to accurately predict the need for ICU admission, vasopressor support, or treatment failure. They also are dichotomous in terms of their laboratory values, their vital signs. So systolic blood pressure less than 90, you get a point. If it's 91, you don't get a point. Not very useful. It would be more useful for a dynamic assessment over time. And as Laura pointed out before, they definitely fail to consider other reasons to admit, such as exacerbation of comorbidities, unable to be treated as an outpatient. Maybe people have cognitive impairment, they can't take care of themselves to provide their own antibiotics, and social factors are also a big concern. So we wanted to look at how well does the PSI and the CURB-65 compare when looking specifically in a young adult population. There weren't really any studies that have been done in just young adults, particularly those less than age 50. There was one that I found that was wanting to compare how well these scores performed in 3 different age groups. The younger adult population would be 18 to 64, so not quite the population that we're interested in, but this is the only study I could find. So they wanted to see how accurate these scores were at predicting 30-day mortality. And essentially what they found, if I can get my thing here, is that overall the PSI tended to have a very high sensitivity and negative predictive value. However, the CURB score had a low sensitivity but a very high negative predictive value. When you're actually looking at the younger population, though, these scores were less accurate than compared to the entire cohort. They also did use something called a ROC curve analysis. It's a statistical technique. I'm not overly confident if I can explain it very well, but as with discussing with Shelley, when you're looking at a ROC curve, you're measuring the area underneath the curve, which is shown here. Yeah, let's put these in here. And basically, a greater area would suggest a more useful, maybe, clinical prediction rule. But the area under the curve is not how well patients are classified. It's only how well cases are ranked to non-cases. So in an extreme situation, if you had a group of physicians that didn't necessarily understand how to utilize one of these scores, and they grouped everyone into very low risk categories, as long as the patients that were the most sick were grouped higher than those that were sick, then you would still have a very high AUC. And in fact, in this study, you do see that, as you, which I'll show you here. So for the CURB-65, they had very high AUC values as compared to the entire cohort in young adult population. But when you actually look at this, 18 of the non-survivors there were 18 non-survivors in the CURB-65 category, of which 14 were misclassified as low-risk patients. So again, the take-home value of this is that you cannot reliably use the PSI or the CURB-65 in the young adult population with the current cutoff values. So sort of switching gears here, the Infectious Disease Society of America and the American Thoracic Society, which is the IDSA, ATS, they wanted to try and derive a set of guidelines that would help clinicians decide whether or not a patient needed to be admitted into the ICU. Again, this is another two-step rule. I won't say rule, but the guidelines require 2 steps. So the first step is they want you to use the PSI or the CURB-65 in order to decide, is this patient in need of admission into hospital, or are they suitable for an outpatient treatment? Once you've decided whether or not they can come into hospital, then you use this criteria to decide if they're sick enough to require an ICU admission. Their criteria is if you have any one of the major criteria or 3 or more of the minor criteria, they suggest ICU admission. So these are their criteria. And these guidelines were actually derived from a study that was done in 1998. At that time, there was the American Thoracic Society had a set of 10 severity criteria that they found were associated with severe pneumonia. Their rule was that if you had any one of the criteria, that you were considered to have a severe pneumonia. So this study wanted to validate the ATS criteria at that time, and then they wanted to further modify the criteria to create this prediction rule for ICU admission. So when they actually looked at the ATS criteria, the specificity and positive predictive value was very low. So they failed to validate the ATS criteria as it currently stood. They then wanted to go ahead and look at prediction of ICU admission. So they looked at the variables, they identified those that were independent predictors of a need for an ICU admission. And at that time, they found the rule that would be the most specific for requiring ICU admission was 2 minor criteria and 1 major criteria. As you can see, specificity was 94%. However, of those that actually had severe community-acquired pneumonia, 22% of them would not meet this rule as it currently stood. 10 of them only had 1 minor criteria, and 3 patients actually had none of the criteria. So the take-home message from this again is you have to be cautious when using these guidelines. Apply your clinical judgment. And the other score that we'll talk about today is a relatively newer score. I don't know if anyone's familiar with it. Do you guys ever heard of SMART COP? No? Anyone? No? Okay. So SMART COP wanted to, again, derive a rule that would accurately predict the need for not ICU admission, but either mechanical ventilation or vasopressor support. They thought that ICU admission was too subjective, so they wanted to look at specific outcomes. So SMART COP, again, it was an inpatient study. They looked at the variables that were independently associated with either mechanical ventilation or vasopressor support, which they called I or VS. And interestingly, they did a separate data analysis for adults under the age of 50 when they were coming up with their data points. So their mortality overall, 5.7%. Out of those that require ventilation, it was 15.4%. They had a 13.4% rate of ICU admission, and 10.3% of the patients studied required either mechanical ventilation or vasopressor support. When looking at the PSI and CURB 65 in this group, they found that of those requiring mechanical ventilation or vasopressor support, 10% of them would have been classified in class 1 or 2 by the PSI, and 16.5 would have been into class 3. And remembering the PSI classes 1 to 3 can technically be considered for outpatient treatment. When you're looking at the CURB value, again, it's actually even more impressive. 33% would have fallen into group 1, which would be our group of interest, and 28.6% would have been in group 2. These, again, could potentially be patients that are treated as an outpatient by those scores. They then took this and they validated it in 5 external databases, and they came up with this. 0 to 2 points, you'd be considered low risk. Anything 3 or greater, you are moderate risk, and they would suggest possible admission into hospital. So when they actually looked at how well this compared to the PSI and CURB 65, it was more accurate at predicting those not needing mechanical ventilation or vasopressor support than the PSI or the CURB 65. But again, the rule was derived and validated in inpatient population. It's a very new rule. It has not been externally validated very well. So it's still not quite ready for prime time yet. Another study that was done a year after the SMART COP came out, again wanted to compare how well the CURB 65, PSI, and SMART COP did at predicting the need for ICU admission. Sorry, this one was mechanical ventilation or inotropic support. And again, SMART COP did outperform the other two. PSI and CURB 65 both would have missed 45% of those that did eventually require mechanical ventilation or vasopressor support. PSI would have only missed 15%, but still that's a relatively high percentage score. There are other severity scores. We're not going to go into them. They may or may not become more prevalent in the literature. Right now, they're only based off of single studies. So going back to the initial cases, did you want to do this? Or do you want? Okay. So I'm going to calculate the scores for the first case, a 25-year-old woman. So PSI, two-step process. First, is the patient low risk? She have an age greater than 50? No. She didn't have any coexisting diseases. And in terms of the actual cutoff values in the PSI, she would have not met any of them. So she would have been classified as low risk from the PSI. CURB 65, again, she met none of the cutoff values for CURB 65, so she had a score of 0. So she would have been low risk and requiring outpatient or suggested outpatient treatment. When she came back, same thing. Still didn't meet any of the PSI criteria. She had one change in the CURB 65. She had a urea of 7.7. Gives her a score of 1. She still falls into group 1, so she would be a mortality risk of 1.5%. Suggested outpatient treatment. For the take-home message for her, or in general, is you can't use these scores in young adults. They're not measuring our outcome of interest, and young adults tend to be underclassified, so you have to rely on your clinical judgment. For case 2, the 21-year-old, step 1 is in low enough risk to be classified into class 1. He's less than 50, he had no coexisting diseases, and again, physical exam, he did not meet any of the cutoff criteria. So he would have been low risk for outpatient treatment. CURB 65, again, he meets none of the cutoff values, he has a score of 0, and would be suggested for outpatient treatment. I don't have any of the information about his admission, so can't recalculate whether or not he would have met these when he was presenting 3 days later. But the take-home message again is we know what happened to him. He ended up being quite unwell, so clinical judgment again is required. So in summary, young adults with pneumonia don't present in a similar fashion to older adults. They have some unique risk factors. There's a very low mortality rate among this group. And the PSI and the CURB 65, which are the most well-known risk scores, underestimate severity in this population, primarily because they are only looking at 30-day mortality. These scores were derived in an inpatient population, and they're not looking at our outcome of interest, which is the need for mechanical ventilation or pressor support. There are new scores on the way that seem to be better at predicting the need, or maybe not predicting the need of mechanical ventilation or pressor support in this population, but they still need further validation. So take-home message from the whole thing is you can't really confidently use these scores, particularly in the young adult population, and you need to rely on your clinical judgment. Cool. And that's it.